My name is Susie Hudson. I'm the Clinical Director here at NADA, and I'd like to welcome you along to this very exciting webinar on how to use ATOP data for service evaluation, quality improvement, and research activities. All participants today are joining in listen and view only mode. However, after the presentation, there will be a question and answer session. So I really strongly encourage you to submit questions at any time during the webinar into the Q&A box located at the bottom of your screen. You might need to move your cursor around just in order to see the Q&A box. But you can enter questions in throughout and we'll come to those questions at the very end. The webinar is also being recorded today and will be available for viewing on the NADA website in coming days. And so joining us today, we're very fortunate to have Professor Nicholas Linzeris. He's the Director of the Drug and Alcohol Services South Eastern Sydney Local Health District. Also, Dr Rachel Deacon, and she's currently the Research Associate with South Eastern Sydney Drug and Alcohol Services. And also Christy Mammon, she's the Program Manager with Koki. And I will now hand over to your hosts and see you at the end for questions. Over to you, Rachel and Nick.
So initially want to thank NADA for allowing us the opportunity to, this is part two. Last week or 2 weeks ago, we looked at some of the clinical uses of the ATOP. And today, Rachel, who's our lead research associate on the Koki project, is going to walk through on how we actually utilise some of the information coming out of the ATOP for service evaluation, quality improvement and research activities. Before we get started, I just want to acknowledge the traditional custodians of the land, our Aboriginal colleagues, and pay tribute to Aboriginal elders, past, present and future. I'm on Gadigal land and I believe Rachel's also on Gadigal land. And on that, I'll throw it over to Rachel. Thank you.
Okay, Nick. So the learning objectives we have for this session, by the end of this session, we hope you have a good overview of how you can use ATOP data for describing the clients attending your service, for evaluating a service or group by looking at client outcomes over time from the ATOP items, and get some ideas of how this could be used for your own quality improvement activities or for clinical research, and also to get an overview of how to review your data quality and how to transform that raw data into more useful items. I'm now just going to switch back to Nick to give the introduction.
Muted. Last session, we spent the session looking at how we use the ATOP clinically. And just to really recap that the ATOP is a 21-item instrument that was designed really to be used in clinical settings and with a focus on sort of outpatient community settings where often time is limited with clients. And so we needed a single tool that we could use for a number of reasons. So the ATOP there, and again, Rachel will be going through further details on where you find the ATOP and some of the manuals around using it. But you can see there are a number of questions around substance use and related risks and general health and wellbeing over the preceding 4 weeks. It relies upon responses directly from clients. So it does not require any interpretation by clinicians, but to date, we've only validated it to be administered by clinicians or researchers. And we'll be looking in the future about self-administered ATOP, but for now it is an administered questionnaire and generally takes around 5 to 10 minutes to complete. We have validated for face-to-face and also for telephone use. Next slide, Rachel. Many of you will be familiar with the clinical care standards from New South Wales Health in the AOD sector, and those include intake, comprehensive assessment, care planning, risk identification monitoring, ongoing treatment monitoring and review, and then transfer of care documentation. And then the ATOP can be integrated into can be used for each of those steps in the process. And that's what we looked at in some detail at the last forum. And again, just to highlight that when we think about how we use the ATOP, we can use it for a brief structured assessment, for risk screening, for care planning, for routine monitoring of client outcomes and risks, and for standardising how we communicate between clinicians and between services in some of our transfer of care documentation and approaches. And then the sixth element is how we use it for service evaluation and quality improvement. And that'll be the focus of this session. Next slide. Now, a key issue with sort of understanding, asking the question around whether or not a client has made significant improvements or has deteriorated over a period of time, I suggest that we can always think of this in terms of we do this in two ways. One is at an individual client level. And at an individual client level, it's really about working with the client and reviewing repeat ATOPs that are done over time. Sitting down with the client and looking at what the client's goals were for a particular domain. So for example, in the example we've got there, we've got cannabis and health status. This is the psychological health. And this is an example of looking at 4 ATOPs done over a 9-month period. And you can see there how we can sit with the client and track what's happened to the client's cannabis use and how that's impacted upon their psychological health over that period of time. And these are some things we looked at the last forum. So at an individual client level, the question, sorry, back Rachel, it's gone on auto present again. At an individual level, you sit down with the client and you say, so what were your goals around your cannabis use? And what were you hoping would happen also to your mental health? And you really would sit down with the client saying, so how do you feel about the changes that you've made? Do you think treatment's working? And would we say that you've had a good outcome to date? So that's how we do it at an individual client level. And I would argue there is no substitute for doing that with individual clients and exploring their own perception around how well treatment is working. However, at a service level, when we may well be looking at thinking about what happened to dozens or hundreds of clients that are in one of our services, we need a more standardized approach that allows us to assign outcomes across groups of clients. And that was the sort of the thinking that led us to the Koki outcome metric development. Next slide. Now, this is a really busy slide, and we're not going to go through all this. Really want to highlight that the processes that we follow to come to the Koki outcome metric, and that's what Rachel will be walking you through, is what is the outcome, the Koki outcome metric. But just so people understand, there's a lot of work that's gone into this over the last 5 to 10 years. So some of it has been about getting the necessary research around the ATOP instrument itself, understanding things like how much change is required for reliable change, as opposed to what might simply be measurement error, understanding the role of clinical cutoffs in an ATOP, and some of the issues around reliability and validity around the scale. So a lot of that work's been done over the years. We've also done a lot of work consulting, particularly with service providers and with consumers as well in various forums and various projects over the years, get a sense of what do clinicians and consumers understand about this concept of how much change is meaningful change and how do we assign outcomes to treatment episodes. And that then has been linked with a lot of the work about, well, and how do we use the data and actually manipulate the data for it to make sense with those other aspects of work. And we synthesize all that into what we call the Koki outcome metric. So that gives you a sense of the work that we've done and why we've done it to get to this point about using the data that we collect clinically and how that will allow us to do the service evaluation. And on that, I'm going to hand back to Rachel. So over to you, Rachel.
Thank you, Nick, for that introduction. So I'm just first just going to recap. These are various ways that you can use your ATOP data to characterize client groups for service evaluation, clinical research, and it's also really useful to combine the ATOP data with other sets of data, such as the New South Wales minimum data set. As to why you would like to do this, using ATOP data to characterise clients at your service, that can help you to target workforce development. It can ensure that you've got good suitable staffing profiles to meet your clients' needs. With looking at ATOP changes over time, you can identify emerging trends within your group. You can see if a new service or a new way of doing things is delivering good outcomes, and identify populations of clients who might need tailored services. So a very quick refresher, as Nick went through the ATOP last week. So there are three main types of variables coming out from the ATOP. First, there's questions on the number of days that a substance was used or something was done, and this gives a number out of 28. So these are from the substance use variables, from injecting, and number of days work and study done in the last 28 days. Then there's a series of yes/no risk questions for things such as whether or not if someone's injected, if they've had unsafe injecting practices, social risk questions such as homelessness, whether people are responsible for caring for children under 5, children 6 to 15, whether someone's been violent or had violence done towards them, if someone's been arrested. So those are yes/no questions. So substance use and days of work and study, those 0 to 28 day measures, can also be categorised as yes or no. Then there's 3 0 to 10 patient-rated health status questions, and these are for client-reported psychological health, physical health, and quality of life. As mentioned in a previous slide, our validation work has determined cutoffs for these 3 0 to 10 scales that indicate where a client is likely to have moderate or significant concern in this area, which would need clinical follow-up. So the cutoffs we've determined are if a patient is rating low between 0 and up to 5, that indicates a moderate to significant concern in the area. And a scale, a rating of 6 or above, between 6 and 10, a client mostly has no or mild concern in that area. So then thinking about those different ATOP items, you can use those to describe the clients attending your service. I'm showing here one example of how you can use this graphically to show what the characteristics are of your clients. Here's a sample of about 500 clients who were new to the CESLID drug and alcohol service over several years. And graphed here, we've got firstly, presented here are mostly the raw ATOP data items without much manipulation done. We have already, though, combined a few of the items. For example, here, it was useful for us to see at a glance for this group how much overall non-OST opioids were used. So we combined heroin use days and other opioid use days into the one item. We also, just for brevity, combined the 2 violence items, either if someone had been violent or had violence inflicted on themselves. And the psychological, physical health and quality of life, we're now representing in terms of those 2 categories, whether a client has moderate to significant risk of concern in that area or no to mild concern. So what other ways would you manipulate or sort of start to work with ATOP variables in order to make greater sense of them? So for the substance use variables, you would have noticed on the last slide, the substance use was peaking at no or low, no use, and then at the 28-day use. And we see this quite commonly in different ATOP data sets. So based on that common distribution and also consensus from our clinical consultation processes, We've determined that a good way of dividing up that or categorizing that substance use data is to categorize it as no use, low use, which has been chosen to be 1 to 12 days of use, equivalent to use of 3 days or less, and then high use, 13 to 28 days. Then the social and wellbeing variables, there's quite a few pairs there. From the last slide, we had already combined the 2 violence variables to see how many, what proportion of clients had violence happening around them, but also whether a client is working or studying, they can be combined into one stacked variable. Homelessness and housing risk, and the caring for children, the 2 items there to get a measure of how many people have caring responsibilities. And so with these additional manipulations of the ATOP variables, here's another example of how ATOP data can be displayed. This is for another a hypothetical team, new clients, around 200 new clients coming in over a 6-month period to this service. Mean age 38 years, and about 1/3 of them were female, which is fairly characteristic of drug and alcohol services. So with this group on the left, we've got substance use variables portrayed in these 3 categories of no use, low use, and high use. So in this group, alcohol is the dominant substance used here, with sort of 40% indicating high use. There's also some use of benzodiazepines, cannabis, and stimulants as well. An additional manipulation we did here was we combined cocaine use and amphetamine type stimulants use. This may or may not be a good thing for you to do with your data, depending on quality of data and what you're actually looking for. The middle item here shows how those social risk variables, now that they're combined into stacked variables, can show at a glance how many clients are either working or studying, which is a marker of some involvement in community and society. So here, around 20% of clients are either working or studying, or both. Overall housing risk, it's around 15% here. Around 15% of clients have caring responsibilities. That's for children, whether they're under 5 years, 5 to 15, or both. And whether they've been arrested the last 4 weeks, and then people with violence around them, whether they've been violent, suffered violence, or both. Easy to see at a glance what's going on here. And then finally on the right is the psychological health, physical health, and quality of life variables displayed as they have been in previous slides. So then the next step from after looking at cross-sectional data, whether it might be clients coming into a service or all clients within a service, is having a look at client outcomes over time. Now, in this group, one way to approach client outcomes is to use traditional descriptive statistics. In this group, we've got 108 clients. They were enrolled in one of the Koki evaluation studies and had ATOPs completed at baseline when they came in, and then at 3 months. So some of the key ATOP items for these clients were alcohol use, as their principal drug of concern was alcohol, and then psychological health, physical health, and quality of life. Looking at the group changes over time, so there is a statistically significant decrease in alcohol use within this group. And there was also a statistically significant increase in the quality of life. But this approach, it doesn't say anything about how many people decrease their use or increase their use, or whether their psychological health decreased. Only the overall group results are portrayed here. And it's also important to consider, is the amount of change we see here, does that have any clinical meaning? The change in the quality of life measurement, for example, it's changed overall for the group from 5.8 to 6.5. That's a change of less than 1 point. From a 0 to 10 scale, does a change of less than 1 point have any clinical meaning? That's what we have sought to determine. Sorry. So the Koki metric, which I'm going to step through now, another way of looking at ATOP data, we've developed a range of data rules and algorithms based on looking for how much change in an ATOP score, primarily the substance use items and the 0 to 10 scales, how much change is clinically meaningful, but also including measurement error in the instrument itself. And what we've determined from our work is that for substance use, a clinically meaningful change is a minimum of 4 days or more than 30% change in the number of days change of substance use. Physical and psychological health and quality of life, 2 or more points is a clinical meaningful change. It's also important to have a look at where clients start from. If a client comes in not using the primary substance of concern at all, and they maintain no use, that doesn't rank as a clinically meaningful change because there is no change, yet 0 use is a good outcome. So for those clients where there's no or low use, maintaining no or low use in the Koki metric is assigned a successful outcome. Whereas if someone doesn't change, but they started on high use, that is an unsuccessful outcome. Similarly, for physical health, psychological health, quality of life, maintaining a high rating is good, so that's a successful outcome. Maintaining a low rating is an unsuccessful outcome. So let's have a look now at applying these rules graphically, starting with data from the same group of clients on the previous slides. 108 clients enrolled in a Koki validation study. Principal drug of concern is alcohol use, and the ATOPs were at 0 time point and then at 3 months later. So this slide shows the clients split, first of all, into whether they had low or no alcohol use at baseline or high use. For the clients who entered treatment with no or low alcohol use, at follow-up, there's then 4 potential outcomes for them. They could have decreased their use. They could have not had a clinically meaningful change in their use, either stayed the same or only changed by a couple of days. They could have maintained 0 use, or they could have increased their use. And then for people who started the study with higher use, 13 to 28 days, there's 3 possibilities: decreasing use, staying the same, or increasing. Then when we allocate outcomes, this is the same slide, but now we're color coding those outcome categories as to whether they're a successful outcome or an unsuccessful outcome. So for those clients who were in the low use at baseline, but did not change significantly their days of use, that's assigned a successful outcome. But the same thing in the high use group is an unsuccessful outcome. And so then we step into combining the outcome groups into successful and unsuccessful outcome. And then finally, combine the low use at baseline and high use at baseline groups to get an overall, at the graph on the right-hand side shows from the change in days of alcohol use within our sample, 108 people, who's had a successful outcome in terms of alcohol use or who's had an unsuccessful outcome. And we can see here that nearly 3/4 had a successful outcome in terms of their alcohol use. I'll just note here, and Nick has spoken about this earlier, measures of success and non-success here are not meant to relate to individual clients' goals. Clients' goals should be something that are worked out individually with a client and a clinician. But these are the rules we are talking about here are designed to be used for group data, for data en masse. Anyway, continuing along, applying those Koki change metric rules now to psychological health. What does that look like? So on the left here is a chart showing the change in psychological health separated by whether clients had no or low concern at baseline, that's a score of 6 to 10, or whether there was concern at baseline. And there's 3 outcome options here. People can either improve, stay the same, or deteriorate. The graph on the right is where we've now color-coded those outcome categories by whether it can be considered a successful outcome or an unsuccessful outcome. So if someone is no or low concern at baseline and haven't changed, that is a successful outcome. But if there was concern at baseline and there's been no change, that is unsuccessful. And finally, similarly to the to alcohol, combine those successful and unsuccessful outcomes, and then combine the 2 groups of clients, whether there was no concern at baseline or concern, into the one item. And then the chart on the right there is showing for psychological health for this group of 108 patients, comparing their baseline and follow-up ATOP scores. Did they have a successful outcome on psychological health or an unsuccessful outcome? And about 2/3 had a good outcome. When we then follow through and see how that, then apply those to also similarly physical health and quality of life, and bringing back in days of alcohol use outcomes there. This is an example of how a summary of outcomes from ATOP change data can be portrayed. On these are, we're not showing here all of the ATOP items, but for this particular group, these are key outcomes. And so here's a way to show it clearly, sort of everything all together. Now, before you dive into jump straight into using your ATOP data, there are a few caveats. There's a few things to look out for, particularly around what coverage of ATOP data you have for your particular service or client group. If you want to have a look at what clients look at entry to service, then have a look at how many clients at baseline have ATOPs. If it's less than 3/4, 2/3, then the data you have is not likely to be representative of all the clients attending your service. And especially at follow-up, when implementing doing ATOPs in a routine way clinically, usually we find that baseline ATOPs can be quite well completed, but follow-up data can be a bit patchy. So if you're wanting to look at follow-up data, if you've only got data on a minority of clients, you won't be getting the full picture of what's happening. And it would be advised at that point to not yet look at outcomes, but look at ways of building up how much follow-up ATOP data you have in your service. You need to implement data rules before you start diving in as well. What specific time frame are you looking at? What's specific types of clients, whether it's entry to service or clients cross-sectional. And just check also if any variables have a lot of missing data. Sometimes the 0 to 10 self-rating scales aren't particularly well completed. So just have a look to see what quality of data you have there. Now I'm going to go through a couple of, you could say, real life examples of how the Koki metric, the Koki outcome metric rules have been applied. And these are both within CESLID drug and alcohol services. Firstly, a quality improvement example. Some years ago, a new therapy group was started up, a dialectical behavioural therapy group, which looked at patients' emotional regulation and also their substance use and techniques that clients could use to improve both of these. As a new service, it was important for the service to evaluate how they were going. Was it actually of use to clients? And these are some of the results from 45 people who attended the groups. On the left, we've got descriptive statistics showing changes in days use of the client's principal drug of concern. There was a range of substances. The clients attending could have a variety of principal drug of concern. So we measured the one that was most important for clients themselves, and then physical health, psychological health, and quality of life. On the descriptive statistics here, the only statistically significant change that we saw was in quality of life, which improved, which is good. But overall for the group, it only improved by 1 point. Now that's below our clinically meaningful cutoff. And that change is also only representative of the group as a whole. It doesn't indicate how many clients improved in that group or how many clients did worse from that group. So on the right-hand side, using the same data but applying the Koki metric rules, we now have a different way of looking at the data, looking at how many clients had a successful outcome or an unsuccessful outcome on these 4 ATOP items. So in the top left, days use of their principal drug of concern, 90% of clients had a good outcome, a successful outcome. 2/3 for psychological health, a good outcome, and physical health as well. And quality of life, nearly 3/4 of clients had a successful outcome. I'm now going to show another example. This was a much larger sort of whole of service evaluation using ATOP data and other data sources as well. So this is where COVID gets mentioned, of course. So when COVID hit New South Wales in 2020, whenever that was, in March last year, there was an urgent need for opioid treatment services in CESLID and New South Wales wide to adjust how they were providing services. So traditionally in New South Wales, opioid treatment services dose clients daily at central clinics. So there's lots of congregation of clients at clinics. But with the risk of COVID and the infectiousness of it, there was an urgent need to have to reduce client contact with clinicians in order to protect clinicians as well as staff. And to reduce the need for clients to have to keep coming into clinics, there was an increase in how many takeaway doses clients were allowed to have. There was also a move to where it was possible for clients to dose at their local pharmacy just to reduce that congregation of clients. And depo-buprenorphine was starting to be introduced to the service, and where it was clinically recommended and where a client was interested, that was also one of the things that operated there. So the main change was around the increased access to takeaway doses, and there was a real need to assess the safety around that. Was the client body with this big change and the risk and the potential risk to clients and community with increased takeaway doses? There was a need to assess how clients did. So because we were already collecting routinely ATOPs and other clinical data for our OAT client group, we were able to use this routinely collected clinical data. We already had baseline or pre-COVID data available for most of our OTP clients. So we're able to implement an evaluation really quickly during a crisis where there was no time to set up a bespoke research study, and where there was no time to recruit clients to a study. So we were able to measure, we were able to get ATOP data for OTP clients, around 500 of them in Cessla Drug and Alcohol Services. We had pre-COVID ATOP data and then after implementation ATOP data. We also had MDS data, so demographic data, and also dosing data available to us. So we knew how people's dosing regimes changed. We had a lot of results. I'm not going to go through all of them, but just to show quickly some of the changes in substance use that went on within the client group. So between pre-COVID and post-COVID, this was separated by on average by about 9 months for each client. So opioid use went down, as did benzo use, but there was an increase in cannabis use. One of the main outcomes we wanted to measure in this evaluation was there a deterioration in clients? And we measured that by having a look at their days of substance use for those substance categories that were most important or most related to their OAT medication. So we were really interested to see if people's opioid use increased, alcohol use, stimulant use, and also benzodiazepine use. So one of our main outcome measures was, did a client increase on any of those 4 categories by that clinically meaningful amount of 4 days or more? So we had a look at people's takeaway conditions before and after COVID, and if they had a deterioration in their substance use by a clinically meaningful amount. And the conclusions from this were most clients generally did well. Most clients were retained in treatment, and in general, positive social and general health outcomes we saw. There was a small proportion of clients that had that clinically relevant increase in their substance use. So that's an increase in either opioids, alcohol, benzodiazepines, or stimulant use. But that was not associated with increased takeaway dose provision. In fact, the opposite occurred. In general, as clients were assessed and seeing whether they could get extra takeaway doses or not, it was generally the risk assessment framework that helped clinicians through this process, enabled a large portion of clients who were suited to getting more takeaways. They were able to access them safely, and they did well in terms of their social and general health, and especially their substance use outcomes. And this was also the first real test, the ability of our electronic medical records system in Cessla Drug and Alcohol, using information that had been collected, not for research at all, but for clinical purposes. We're able to rapidly change to using that data for a research purpose, to evaluate a large service system, to do it rapidly in a crisis where there was no time for bespoke research procedures. And as it was routinely collected data, we had data available for most of our clients. So we were quite confident with the outcomes that generally clients did well. We knew that applied. It was data from a good proportion of our clients, so we were quite satisfied that our clients did okay. And now some of those changes in the opioid agonist treatment service in Cessla Drug and Alcohol, we're looking at holding on to permanently as they benefit both the clients and the staff. So that's one example of how ATOP data can be used for service evaluation. So I'm coming to the end now, and I'll just do a little quick summary of what we've gone through here. So I've mainly gone through how applying the Koki outcome metric, the system of rules and algorithms that we've developed with both research and statistical input, and also input from clinicians and services themselves. Applying these rules, it enables you to better look at your ATOP data, to get easier to visualize summaries of characteristics of clients, such as clients entering service, clients out of service. And it also allows you to have a look at clinically meaningful change in your client groups. And applying this metric, you can then use ATOP data, not just for describing your clients, but apply this also to quality improvement projects and to research projects as well. There's further information available, of course, on the Koki web pages. And we've also got some extra materials to assist people who are starting to use their ATOP data in terms of manuals, some Excel templates and so forth. So yes, please take a look at the website, and please contact us if you'd like more information. And here is the ATOP project team, or Koki project team. Thank you.
Thank you so much, Rachel. It's really exciting to see the data come to life. Please, I encourage anybody who has a question about how they might use their data, how they might describe it, to enter their questions into the Q&A box at the bottom of your screen. If you just move your cursor, you'll be able to see that Q&A box come up. While we're waiting for that, Rachel and Nick, I thought I've got a couple of questions here. And I wondered, you talked a little bit earlier on in the presentation about the follow-up data, and we know that that can be a bit of a challenge for people on the front line. You talked about a 3-month follow-up. How do you try to ensure or encourage your workforce to follow up the clients with getting that follow-up data? How do you do that? And what happens if it doesn't happen right on that 3-month mark?
There's a variety of ways that's done. Part of it is we've been working on this system on the Koki program for quite some years now, and we started with paper forms that then had to be entered into a bespoke database. Now the form is within the EMR system itself, which all clinicians work on. So now there are built-in reminders. The ATOP, that assessment, it's built into part of the assessment form, so it's pretty hard to miss. The follow-up ATOPs, we've been able to, over the years, present more data back to our clinicians. So that's been, good for them to go, oh, well, if we have the data, then we can make all these pretty graphs and talk about changes and so forth. So that can be a bit of an incentive for clients. And then within, clinical management teams as well, there's sort of more and more, okay, what's our level of ATOP review? What's the percentage at? So, try and keep it up there. Nick, do you have?
Yeah, look, I've just had that it's really sort of a change management process, if you think about it, and we approach it from a change management process. So here is an approach to doing our work that historically wasn't sort of routine in AOD services. The New South Wales AOD Clinical Care Standards has identified reviewing your clients and monitoring how they're doing as one of the core standards. So, we've now got the direction coming from on top that this is what we should be doing.
Yes.
We also need to, there's workforce development issues. Our staff need to know how to do these things and how to use them. Again, look, these instruments and scales, it's not about doing it because your manager said you had to do it. It's actually doing it to improve client care. So it's about and then understanding how to use something like an ATOP or a K10 or a whatever scale you're going to use. It's not there just to tick a box. It's there to improve patient care. So a lot of that stuff about how do you feed back to clients around their outcomes and so forth. So there's workforce development issues. We've got the policy settings through AOD clinical care standards. We've actually found, though, also, if you think about a lot of things that drive clinical change, things like improving IT systems.
Mm-hmm.
So having reminders going back to clinicians, hey, look, these clients need, this thing done by now, their global care plan has expired, and it's time to redo it. Those kinds of feedbacks, which we understand are really important, that building those things into clinical information systems are one of the most effective ways of getting clinicians to implement that kind of work. And that's been shown in lots of QI research around the world. Those kinds of decision support systems for clinicians are really helpful. And feeding back to, as Rachel said, feeding back to staff and to services, hey guys, here is what your clients look like, and here's how we're traveling, and here's, it looks as though we're doing really well in these areas, but have a look, doesn't seem we're doing well in these groups of clients. So it's actually starting to get clinicians to actually think about what the information is telling them.
Yeah, I couldn't agree more, Nick. It's really, I suppose, incumbent on us to try to bring, as you say, bring that to life. And what you've demonstrated today, Rachel, really is extremely engaging, and people can start to understand and interpret what's happening there. Another question for you both is about that interpretation, and you really gave a great comprehensive understanding of how people should be interpreting the data and how important that is. Are there other things that we can do to help? Because obviously a lot of the data we have may be looked at by a funder or someone external to our organisation. What are some of the things that you all do to help someone interpret the data you provided? And how important is that?
Look, I might start, and then Rachel, if you want to add, or if Christy wants to add, because Christy's been doing a lot of this kind of work. So the first thing is actually understanding how to present the ATOP data. And again, you saw what happens if all you're doing is presenting mean changes. That often what you see is just a blancmange kind of there's no real shift happening, or there is, it's a mind, you saw, for example, Rachel demonstrated, if you just do mean scores, you may get a slight, you went from 5 to 5.4. And if you've got lots of patients in your data, if you're looking at several hundred people, that's probably statistically significant, but it's meaningless. It doesn't really help us understand what happened to those clients or to that service. And that's why, we've sort of identified the need to apply individual outcomes for individual clients that you then group. And to do that is just having, a consistent approach so that it is apples and apples and apples, not apples, oranges and bananas. So actually having sort of a way of presenting the information, I think, is really, really important in a way that is meaningful. And it's why we see things like being able to report the proportion of clients who had a good outcome is more meaningful than what was the average outcome for the average person, because it doesn't really add much. So that's probably, I'd have to say, is probably been one of the key issues. The other thing that we haven't really started to do well yet in the AOD space, and indeed in a lot of healthcare settings, is the issue of benchmarking. And now benchmarking is a loaded term because people think it's something that gets used to, I don't know, look at KPIs for your funding or something. And that's really not what we mean by benchmarking. Benchmarking is, how do you allow services that are of a comparable nature to sort of compare, well, how are you guys traveling compared to how we're traveling? And seeing, are there things that some services do well that we don't seem to be doing as well? And how did you do that? And vice versa. So it's building from that kind of shared experience between services. And benchmarking in some of the areas of healthcare where this has been applied, what it really is useful for is raising the minimum standard. if that makes sense. So it's not about, benchmarking is not going to make the really good service be better. What benchmarking does is the services that are struggling, it allows them to sort of lift. So it's actually about sort of creating minimum standards. And we've got a lot of work to do, I think, over the coming years to sort of, keep pushing this whole journey we're on.
Rachel, Chris, did you have things to add?
Yeah, I mean, I agree with those 2 points that Nick's made. And the only 2 things I'd add, the first is I think it's really important, depending on who you're communicating with, to still keep that client narrative or the client story to go alongside it. I think that people relate to different information in different ways, and we can communicate really effectively if we use both styles. The other thing, I think it's just about persistence. So if you're presenting back to clinicians and services, I think initially there's, oh, that's data, that's not me, and a bit of a shutdown. But if you just keep taking it back, you find who within your group is a little bit more interested maybe, and you persist, I think eventually you get a little bit more traction. And so it's that persistence in the end that can really make a difference.
Yeah, that's great, Christy. And just on that, there's a question here from Alice. She's asking about some of the links, because presumably where you have some of the information about how to administer the ATOP, do you have perhaps some examples of ways to present the data as well?
I might jump in here.
Thanks, Rach.
Yeah. So on the website, and I'll just
Lovely.
Yeah. So there's these the ATOP.org, AOD-Koki.org, and they are linked. So on the Koki program, we've got ATOP training, validation studies, and through the training, we've then got manuals. We've got manual part 1, which is primarily about how to use the ATOP clinically, and then very shortly we have the manual part 2 coming out, which is much more about how to use your data, all the stuff that I've talked about today, and sort of a step-by-step how you can apply these steps to your ATOP data, and the things, the sort of potential pitfalls you should look out for as well. And it shows many of the same examples that I've used in this presentation, ways that you can display your ATOP data. And in the background we've got like a macro script that can help to adjust data that's come out of the public system, some Excel templates to help people make the pretty graphs. And yes, there's lots going on the website, and lots more to come too.
That's great, Rachel. That's really helpful to understand, because I think people are certainly trying to play around with their data to sort of bring it to life. And I think whatever we can do to support people in that way is really helpful. One final question is really about what you presented there that's incredibly powerful, about a change really in culture and approach around take-home doses of pharmacotherapy. I think it really reveals to people how useful the data can be in changing what has been a long time practice. What's sort of the next steps in that regard? You've released some of these reports. Can you tell us just a little bit about what it'll mean for service delivery in southeastern Sydney?
I think Nick might be best placed to answer that.
Yeah, sure. So CESTID has completed a co-design process for our opioid treatment model of care, which we're now implementing. It's worthwhile saying implementing, because that's also a change process as well. You don't just flick that switch on. One of the things about giving clients many more takeaways, also shifting more clients to community pharmacies, using more depot buprenorphine products, what that has meant is that where once upon a time, most of our clients used to come to our clinics every day, Now, most of our clients don't. And that really changes a whole range of issues about how you work with clients. And that we've had to think through. So a simple change like give everyone takeaways has actually had a range of knock-on effects that we've had to sort of think through about what does this mean for how we deliver treatment? How do we communicate with clients in particular? And I think the COVID period has also shown, yeah, telehealth's great, but a third of our clients don't use the phone, 20% or something. So it's thrown forward a range of challenges about how do you work with, in this model of care. So that's going to be the CESLID model. And I think New South Wales Health is considering whether or not they may pick up on aspects of what CESLID has been doing into sort of broader New South Wales ministry issues. Because I think that, there's an awareness now that with the forced changes that came out of COVID, some of us, and it's not just for OTP, I think this is for many areas of our clinical practice, that the changes that have happened have now allowed some of us to say, well, actually, this works better than what we used to do anyway, and do we have to go back? And we're starting to ask those questions for lots of things, aren't we? Does counselling always have to be face-to-face moving forward? What's the role of an online smart recovery group moving forward? I mean, there's a whole range of questions that we've now got an opportunity, should we have the courage, to actually rethink about how do we provide services for our clients. And of course, that throws open that really this is one of the first times that we even embark upon this process, meaning like seriously in a co-design approach with our consumers and clients, because I think it's fair to say that up until, most of the serious heavy lifting around what AOD services look like was all done 20, 30 years ago. And consumers were not part of that discussion.
And so now we've got this opportunity, I suppose, and the data really helps to demonstrate that. So it's not just that anecdotal, this is how I'm feeling about this situation, but it's very clear. You're able to back that up.
Having the data of what happened in our services, what were the changes, what were the outcomes, has actually been essential and imperative to give us the confidence as clinicians and as an organisation to say, look, we think we can do this because this is data from our services. It's not, a study done in London. This is what happened to our people. And I think that gives us confidence. And it also certainly helps you when you're trying to do change in a sort of, with a ministry or other, I shouldn't say the ministry, but there are often forces of inertia that not everyone necessarily sees change as a good thing. And having data to really support the changes are resulting in improvements, I think is really important.
Fantastic. Well, look, we're really out of time now. Thank you so much to Rachel and Nick and to Christy, and please do visit those websites. We work very closely with the Koki team and we want to do whatever we can to support you in your data collection and interpretation so that it brings it to life and is ultimately going to serve the clients and the people that we see every day. So thank you very much for participating today. A short evaluation survey will be emailed to you shortly, and we would really like to hear from you about feedback on this webinar and any suggestions for other webinars. Also, please visit nada.org.au to see a range of resources specifically around data collection and interpretation, or sign up for our regular emails and publications such as The Advocate. We'll also be sending out a recording of this webinar. Thanks so much for joining us and take good care. Bye.